Thank you very much for inviting me. My session starts a little bit tongue-in-cheek and then it becomes a little bit more serious. But we can make it as light-hearted as you like, really. In terms of my where I'm coming from, I have no conflict of interest, although I work for a private hospital. Oh, should I move that up? Sorry. I don't have any conflict of interest, although I do work for a private hospital group, so it's in my interest for people to have bariatric surgery, but that's about the only conflict I can say. And the other thing is I have a foot in both camps here because I'm 19 years post-op. So I've seen both sides of it and still see both sides of it. So, a little bit here. I think this should appeal to some people here. But certainly when I had my first procedure in 2000, I got most of my information off the internet. My GP knew nothing about bariatric surgery. He said, oh, you don't need that, just go on a diet. And it was only when my mum phoned me crying one day because she'd been diagnosed with type 2 diabetes, and my grandmother had also had type 2 diabetes, that I thought, I think this is a case of when rather than if. And I kind of pulled in the reins, and by complete fluke, one of my friends worked in gastroenterology at St Mary's, where they were just doing some gastric bands. So he gave me all the information. So I got a consultation, went along, and they said, yeah, you're a perfect candidate, but we haven't got any funding, so it'll never be done. So I thought, So I went on the internet, and that's where I got most of my information. But the information on the internet then was very different to what it is now. It was very practical. The patients were incredibly sensible, incredibly sensible. It was very much, these are the facts, this is what you should do. There was hardly anything commercial. But I think there is still an element of, we do get scientists, and in fact, if you look at some of the forums on Facebook, you'll get quite a lot, people like Alex Blakemore, who posts regularly on the forums as a patient, as a PhD. She knows, there's nothing she doesn't know about the science of weight loss. She posts all the time, but people will often rather listen to, Mary, who she's done this, that and the other, and she knows all the answers. And they often have a more powerful voice. In fact, one episode in EastEnders and an operation on there is usually much more powerful to patients than sort of 10 weeks with us, really, unfortunately. So where do patients get their information from? Some of it's word of mouth. The lady in the shop's lost a load of weight, she's had an operation. TV. Now, there's kind of a good TV, like the programmes about weight loss surgery, where you see the patient going through the motions. But people will often see ads on the telly. And certainly some private hospital companies have advertised in the past, this was me in a big pair of trousers, and this is me now, and my life's really wonderful. And that's what we all want to believe. We want to believe that there's a magic bullet that's going to make everything better. Some GPs are fantastic. Some of them are completely clueless. I run a medical or a non-surgical weight loss clinic, and I write quite a detailed letters to GPs recommending certain things, and the GPs will come back to me sometimes. I'll say, I think this patient would be suitable for bariatric surgery. Would you consider referring them? Oh, it's not available in our area. It's like, well, it is. So I write back and I send them all the details about their local CCG. It goes over the head. Internet, good and bad. Magazine articles, Take a Break magazine. You're sitting in the hairdressers, under the dryer. Oh, crikey, this one was done really well. And the Daily Mail, they're absolutely obsessed with weight loss surgery. It doesn't matter, not a day goes by without an article. And if ever it goes wrong, it always says, my gastric band hell. And you usually find it was a bypass or some other up. But it's always my gastric band hell. That's the generic term for anything bariatric. And people just love that because it's exactly what the Daily Mail want to read. Another fat pig that's got themselves fat and they want our money to make them better. That's what the Daily Mail likes to read. And the person sitting at home thinks, my friend can't get their hip replaced because there's all these fat people out there making themselves fat, and it's all their fault and we're having to pay for it. So that's another thing that patients have to live with. And brochures, you do find brochures, picking them up in hospitals are quite good places to find them, but anywhere you can pick up brochures. I flew to Egypt once and there was a brochure fell out of the in-flight magazine about a surgeon in Cairo doing surgery. So people get their information from all sorts of sources. So what are the advantages of the internet? Why do patients go on the internet? It's comprehensive, there's loads of information. There's a load of gibberish out there, but there's also some incredible research and papers if you want to go there. Springer articles, there's incredible stuff on there. It's quick and easy, especially on your smartphone. What's this operation, a SADI? Oh, that's what it is. Okay, you can do that. You don't even have to go home anymore. It's available 24/7. You know, you don't have to wait until ringing the hospital the next morning. It's anonymous. You can ask a really stupid question, or stupid in inverted commas, and no one's going to remember. And it avoids the individual clinician's bias. Now, I use that with a blanket term, and I know that most clinicians aren't like that, but certainly, you've got a surgeon that only does one operation, and they will lean you towards thereof. And it would be lovely if every surgeon said, I only do gastric band, but I think you'd be better suited to such and such an op, go and see my colleague. But particularly in the private sector, that doesn't happen, because I'm not going to lose this patient. And I'm sure there's some great surgeons that will do that, but I'm afraid to say there's quite a lot that don't. Internet disadvantages, completely unregulated. You can write any old gibberish out there, particularly if you go onto Wikipedia. People write nonsense, don't they? Doesn't mean it's true. Not always honest or correct. It's always like whatever you come up with, there's always Uncle Jim that smoked 60 a day and he lived till he was 101, so that means smoking safe. Everyone always knows someone that didn't follow the rules and they got away with it, and people want to believe that. You know, I've never taken a vitamin since my bypass. I don't mean me personally. I mean, these are things people write on there. I've never taken a vitamin and I'm absolutely fine, or I only take, the own brand from Aldi once a week when I remember, and my bloods are fantastic. Well, you're lucky, because that isn't the case for most people. The information is very generic. It doesn't take into account people's personal circumstances. One of the ladies here mentioned it about, where they come from. That operation that was perfect for the lady down the road may be completely unsuitable for you because of your personal circumstances. But all you see is this woman that's lost loads of weight, and you think, well, I want to have that, what operation she had. Potential exploitation, loads of journalists hide on forums, loads of them. You can spot them a mile off, and you can find your words being put in an article sometimes. And maybe they might not say your name, but people have really poured their hearts out before about, history of exploitation and, child sexual abuse and everything, to find that there's an article in Woman's Own that's actually got their own story in it, which is pretty disgusting. I certainly found one of my photos advertising a surgeon once, a plastic surgery photo for a surgeon in Belgium that got one of my photos off a website and put me on their site. And I've never even met this surgeon, so I don't know where they got it from. And exploitation from anybody, really. And some of the information may be commercial rather than clinical. You can get, it sounds like I'm really anti-surgeon, I'm really not, but some of the surgeons will actually either go on posing as John from down the road, or their nurse is on there posing as a patient to find out what their patients are doing. And in fact, there's a surgeon who's not so many feet away from where we are today on a different floor, who has, and one of their patients is their patient advisor. And a lady some years ago wrote, and her experience of the operation, said it was fantastic, the hospital was beautifully clean, it was so perfect from start to finish. If I had one criticism to make, it was that on the night shift, none of the nurses spoke English. And she was immediately got a letter from the surgeon saying, remove that, don't criticise my service. And she said, but I didn't criticise your service, I said the service was fantastic, but she was told in no uncertain terms, remove it. You also get patients being told, if you promote my service, you can come and have your revision at a discount, or you can get your plastic surgery in the same hospital at a discount. It happens all the time, particularly the other side of the channel. I won't say which country. So what's the appeal of the internet over the clinician? It's quick and accessible. It's non-judgmental. It's free advice. Very important if you're either using the private sector in the UK or if you're in America, where just getting a consultation to ask things can cost £200-300 quid. You may well want to go on the internet and ask advice for nothing. And embarrassment, I'm embarrassed to admit that I may need weight loss surgery. I don't want to have to ask my GP, so I'll go on the internet and ask somebody totally anonymously, and no one, I don't have to explain it to anyone. Does it really matter that patients go on the internet? Yeah, patients withhold information. And going on from something one of the ladies said here, certainly it's particularly relevant with psychology. Now, it doesn't happen so much now, but certainly 10 years ago with some services, you had to see the psychologist before you could get surgery. It was a complete rule. And so you'd get patients going on there coaching each other what to say and what not to say so that they could get through their operation. For God's sake, don't mention this. For God's sake, don't mention this. Say so and so and get through it. And I have to say, I was a complete victim of this because I wanted plastic surgery. I wanted a thigh lift. And I went on a plastic surgery for him. Tell him you're really depressed, tell him you want to take a knife and cut your fat off. Well, I did such an Oscar-winning performance. Not only did they refuse me surgery, but they wrote a letter to my GP saying I needed urgent psychological help. So from then onwards, I've had to pay. So the other thing is coaching of prospective patients. I was talking to the St George's team earlier, and one of the patients on theirs, you know, the old-fashioned scales with the weights, they're putting weights in their pockets when they come for their first consultation to overweigh, so that when they come back, they've lost more than their 5% and they get their operation. And I'd never heard that before, but I mean, I guess it makes sense. It's quite sensible. They can also be dazzled by the successes of other patients, and that they may not be achievable, apart from the fact that people often stop posting when they're not doing well. People like to post when they're doing well, don't they? Because everyone goes, oh, you're marvellous, you're a great inspiration. The people that aren't doing well tend not to post after a while. And you'll find that people will look on there, and it might be something like, you know, a gastric bypass, and this person's got down to a size 10, and you've got somebody sitting in front of you that's got a band, and they can't understand why they're not in a size 10 in a bikini, because they can't quite work out that it's kind of not all a level playing field. And they will often fixate on specific procedures, and I'm sure every clinician knows that one. And it may well be just because they had a friend that had this op that did really well, and they don't want to deviate from that because it worked really well for them. We have a bigger problem, particularly in the private sector, where people may be very risk averse, and they'll come in and they've just about got the money together for a band, and you sit and talk to them and you go, really, I don't think the band's going to be the right op for you. And then they'll go on the internet and say, those are money grasping pigs, they just wanted more money, they tried to sell me a bigger operation. So people can get completely fixated on, you know, the patient with lots of reflux that desperately wants a sleeve, and you're trying to sell them Viper. They just want to do a more complicated op to make more money, and particularly may have unrealistic expectations of outcomes. And I think that, I mean, I'm covering this tomorrow in my session on managing patient outcomes, but be very careful with percentages, because when you say things like 50% excess weight loss with a band, a lot of patients hear, I'm going to halve my weight. So I think you need to be a little bit, you know, the percentages are important in terms of risk, but I think it's a lot more helpful to say, if you were 10 stone overweight, you'd lose 5. So you're still going to be 5 stone overweight. So in your case, you probably weigh around so-and-so. And I think that's a bit more meaningful to them, because I think at the end of the day, whatever you say to percentages, patients all think, women think they're going to be in a size 8 to 10 in a bikini, and men think they're going to be a 30 waist. I mean, at a later stage in the day, you have to be talking to them about things like, well, you may well have a lot of excess skin if you reach that point. You probably still won't want to be in a bikini. But I think those are things that we need to think about. So what's the advantage of seeing a clinician? I mean, it's a little bit tongue-in-cheek here. I'm not saying we have all the answers, but I think that, you know, the advantages to seeing the clinician are that hopefully, and particularly speaking to the converted in this room, most of the people that would come to a conference like this are up to date. By definition, they come to these conferences because they want to be up to date. So you come along and see one of the clinicians in this room tomorrow, and they want to do the right thing by you, because they're damned to turn up to conferences, they keep themselves up to date. They've got professional registration. If they talk a load of gibberish or they do something wrong, you can actually challenge them professionally, you know, through things like the GMC, NMC, etc. It'll be a holistic approach with an MDT input. It's not just what that surgeon thinks. They're going to look at your whole picture, not just, oh, you want this weight, let's do the operation that loses the most. They're going to look at the whole picture. And I can't remember which one of you ladies said looking about their family members that have also lost weight. So they'll look at the whole picture there. And also there's MDT input. I mean, I think we all know that there are other people may not agree with us. And I certainly sat at an MDT and I stuck my neck out for a patient once. And I said, oh, please do her revision. I know she's going to lose. And she's done so badly, it's beyond belief. And I really stuck my neck out for this. I was convinced that everyone was being mean. And it turns out that they weren't. One-to-one care, it's not just a generic bubble on the internet, that you're actually going to get care that's relevant to your needs. I say continuity of care pathway as opposed to continuity of care, because let's be realistic, in the NHS they're probably not going to see the same person every time, but you're probably going to work within a unit where there's a pathway, a proven pathway, so you're going to follow that. And there's going to be communication with other healthcare professionals. And you know, certainly one of the problems that we have in the UK when people have their operations abroad is some people come back without so much as even an operation record. You're not even sure what they've had done if it's gone to South America. You know, you're at the mercy of the patient. So at least if you have your operation here, the GP is going to be informed and everybody's got access to the notes so they know what's the right thing for you. Disadvantage, why would somebody not want to see a clinician? They can't afford it. It's probably the number one. And again, particularly that will be in countries that don't have socialised healthcare. They may have to wait for an appointment. If I've got a problem tonight, it's a lot quicker to go on Facebook or one of these support groups and ask Karen on Facebook than it is to wait until tomorrow morning where I may have difficulty getting through and they may put me in for an appointment next week. You know, I want to know now. Personality clashes, we can't all get on with everyone. 95% of patients love me because I sort of say it as it is and I have a bit of a laugh. 5% would have me dead because I know she made me mean to me. So, you know, you cannot please all the people all the time, you know. And I do try and change my approach with different patients, but sometimes we get it wrong. And I'm sure there's plenty of people who don't like me. Location, it may be a hell of a trek to get to the hospital, particularly in a big centre like this. I'm sure you've got patients coming from miles away. You know, it may not be that easy, particularly if you're very big, it's hard to get on the bus. You don't want to trek all the way up to the hospital when you could quickly go on the net. Venue, is it bariatric friendly? I'm sure it is here, but there are certainly plenty of hospitals where they have chairs like this that you can't fit into. Or you're sitting in the waiting room and like the scales only go up to a certain weight. And I've certainly heard from patients saying, oh, the scales only went up to 20 stone, so they made me have one leg on one set and one leg on the other. Have anybody else heard that one? It's crazy. And there was a TV program a little while ago about one of these programs where you go to a fat camp and they train you up. And I was absolutely horrified and got into a very ugly Twitter argument with the guy that runs it because he took them to a meat packing plant where they got weighed on the scales that they weigh sides of beef on. And this was like in front of people as well. Like I would never weigh anybody in front of somebody, even people that reach their target weight. Nobody likes being weighed. So when you've got scales in the middle of a corridor, that's not happening where I work. It's written into our policy that people are never weighed in public. Fear of chastisement. Many clinicians out there, oh, I'm going to read them the riot act, they haven't followed the rules. You know, they're grown-ups. You can't really chastise people anymore. They'll not tolerate it anymore. My mum's generation, she thought the doctor knew everything. My mum would have agreed with anything a doctor said. But everybody's not like that anymore. And embarrassment, I don't really want to go to the doctor. I might have to take my clothes off. I've had surgery in France. You strip off completely. Nobody bats an eyelid. You know, they love nakedness here. In this country, you're just about likely to get them to lift for a band adjustment. You might get that much space if you're lucky, because everyone's terrified of baring their skin. So, you know, there's cultural differences. So how can we make ourselves more appealing to patients as an alternative to the internet? Well, clear and accessible information. Do we give them written information? Is it a couple of old tatty photocopies that haven't really copied well? You know, a lot of hospitals now have done some superb booklets and things that are great. Are we easy to contact, or do you have to leave a message on an answer phone and then you might get a call back? Are we judgmental? Phone apps and internet access. A lot of the private groups now, like Streamline Surgical, they have a patient app, which is fantastic. And when I went to IFSO in Madrid, there's an app that we can't get in this country, but I'm trying to liaise with the French company that make it, where the surgeon has a degree of access and the AHPs have a degree of access and the patient does. And it was designed for patients that may live a long way away so that they can actually upload details about themselves, and everybody's got an appropriate level of access, and it's free to use. It's funded by industry, and that makes life a lot easier. Support groups. Some people love them, some people hate them. You know, I don't know what to say about support groups. The people that go to them enjoy them. Does a support group have to be face-to-face? Could it not be virtual? Doesn't really matter, does it? You pick out what works for your caseload. I mean, even around the country, different communities have different attitudes. What works in Surrey might be completely unsuitable in the North of England. So you pick what works for you. Is your venue bariatric friendly again? I mean, I've already covered that. And could we be nicer? Are we actually nice to the patients, or is it come in, get your weighed, get your scales, oh, you lost a pound, off you go, we'll see you in X number of weeks. Is it worth them coming for an appointment? Do we actually look up from our notes? Are we pleasant to them? You know. So, can the clinician and the internet be friends? Well, I think we can. Liaison with support groups and internet sites. This is actually a mistake. That shouldn't have said who. Oh, what have I done? Oh, sorry.
It's a smart board.
Oh. Oh, hang on. There we go. Oh, no. There we go. No, it was with the next one. There we go. That should have actually said Obesity UK. But Hoop's quite worthy as well, but Hoop is not a bariatric site. The WLS Info has just amalgamated with, I've forgotten who they've amalgamated with off the top of my head, and it's now Obesity UK, and they're fantastic. It's all completely proven information, it's completely accurate. If you go on the sites, there's lots of different forums for plastic surgery, the different operations, so you can get very specific stuff. Bariatric Cookery, the lady that runs this is a gastric bypass patient who's also a professional food writer, and she has a wealth of information on their site. You can buy her products, and in fact we're giving out the Bariatric Bible to all our new patients now, but we're in the private sector. We take a hit on that. We get the book for about £10, but the patients love it because it's a nice little hardback book with lots of beautiful photographs. I don't think the NHS can probably do that, but I think that giving people something makes them feel valued. And our own websites, you know, our own website doesn't just have to be this is how you make an appointment. We could have a private one just for patients only that's got information exchange. What you often find in hospitals now is that the patients run their own support group and the clinicians are not allowed to join. And that's fine, but then your worry is what's actually being written on there, isn't it? Because people can give out incorrect information. There you go. Oh, I didn't realise it was the last one. So I think the internet is a fantastic resource, but never forget that it's not just the information that we give them. What they see on the telly, on TV, on even programs like EastEnders can be really, really powerful. If somebody does badly on the TV, people think it's going to be the same for them. And apparently in EastEnders, my friend's a breast care nurse, and EastEnders, when Peggy Mitchell had breast cancer, in one of her closing remarks at the end of one episode, they were saying about what they were going to do in the future. She said, well, it always gets you in the end, doesn't it? And she said it was profound, the effect it had on patients coming through. They just didn't really feel that surgery was worth having. Just one other thing that I forgot to put this in the slides. In a former life, completely different, I was a midwifery sister in fetal medicine, and I had somebody come in one day when I was doing an ultrasound scan, and they had a long list of questions, and one was, can you tell me what the gain is on this machine? And I thought, well, I could just about remember what gain was. And I don't know. Why do you want to know? Well, because I've read this piece of research, and apparently if the gain is too high, in the South Seas, dolphins crash into rocks and things, and we're a bit worried about the effect on the baby. So people do come up with some crazy stuff. And we had some phone calls last week from a lady who wanted a gastric band that was absolutely adamant that the patient used SeamGuard. I was going, well, I don't really use it for bands. But she'd been told by Karen on Facebook that you must ask for SeamGuard because it makes a safer operation. So she went elsewhere. So they do get these fixations sometimes, and however much we try and explain it to them. So I'm not anti-internet, but I think it should be our friend, but we have to be mindful of what's out there, because a lot of the information, a lot of our job is actually correcting misinformation before we even start. I'm sure everybody's experienced that one. Okay. Well.